Hello, I'm Dr. Timothy Fensky, and I'm going to offer some insights on the latest developments and unmet needs in the treatment of relapsed and refractory diffuse large B-cell lymphoma, or DLBCL, the most common subtype of non-Hodgkin lymphoma. This is an aggressive lymphoma, and when the disease relapses, patients have historically faced a poor prognosis. A large retrospective study published in 2017 called SCHOLAR-1 found that refractory DLBCL patients, defined as patients who had no response to their last chemotherapy or who relapsed within 12 months of an autologous stem cell transplant, only had a 26% overall response rate and 7% complete response rate with their next therapy. Then, with each subsequent line of therapy, progressively lower response rates, shorter duration of response, and shorter overall survival were seen. While transplant is potentially curative after the failure of first-line therapy, at least 50% of patients initially are not transplant candidates or end up not being eligible for transplant due to insufficient chemosensitivity. In addition, almost half of patients who actually do receive a transplant will ultimately relapse. So in other words, about 75% of patients who relapse or progress after first-line therapy do not achieve long-term remission with transplant. And despite some advances in relapse refractory DLBCL treatment prior to 2015, the median overall survival of patients who relapse after transplant remained under 1 year based on a recent multi-center study that looked at data from 2006 to 2015. However, there is some good news here. We have entered an exciting new era in the treatment of relapse refractory DLBCL with the recent introduction of new targeted and immunotherapies that may offer curative potential. These contemporary agents have introduced novel mechanisms that offer different approaches than conventional chemotherapies used to treat relapsed refractory DLBCL. These treatments include chimeric antigen receptor, or CAR T-cell therapy, antibody-drug conjugates targeting antigens such as CD79B, glycoengineered antibodies targeting CD19, and nuclear transport inhibitors. Several other investigational agents are in development, providing even more hope for patients. However, despite having several new treatment options, I have found that clinical scenarios for patients who relapse after 2 or more prior therapies can be challenging. There are many options we can consider for such patients. Some of these, such as allogeneic transplant or CAR T-cell therapy, may be curative in some cases. However, not all patients will be candidates for those treatments. In addition, patients may already be compromised in some ways from age, comorbidities, or prior therapies, making certain treatments too risky. In general, my goal at this point is to provide each patient the best chance for a complete response with a therapy they are able to tolerate and preserve quality of life as much as possible. While I find it encouraging that these new therapies have improved the prognosis for many of my patients, areas of need do remain. In my experience, not all patients are able to benefit from options that provide the opportunity for a complete response in third-line therapy, such as CAR T-cell therapy or a CD79B-directed antibody-drug conjugate. For example, factors such as age and comorbidities may cause me to exclude a patient from being a viable candidate for CAR T. And the wait time during the CAR T manufacturing process is a concern for patients with rapidly progressing disease. I also have to take into consideration the toxicities of these treatments. Those associated with CAR T include neurologic toxicity, cytokine release syndrome, and prolonged cytopenias. Additionally, using a combination regimen that includes bendamustine raises concerns about toxicities such as bone marrow suppression and severe T-cell depletion. Relapsed refractory DLBCL patients also face logistical challenges with available third-line therapies. These may include frequent travel to a cancer center, hospitalizations, lack of caregiver support, and complex regimens with frequent infusions. These, along with financial considerations, have caused some of my patients to forego the potential benefit of newer therapies. While it is promising that options are expanding for third-line relapsed refractory DLBCL therapy, there remains an unmet need for novel therapies that are easily accessible and consider both patient outcomes, such as response rates, durability of response, and toxicity, as well as logistical and financial treatment burdens on patients. In the coming years, I look forward to the emergence of such therapies so that we can expand even further the options we can offer our relapsed and refractory DLBCL patients.